Welcome back to Rooted Exchange. I'm your host, Rachel. Today, I want to talk a little bit about when I became a mom. And I thought I was prepared. I read the books. I took the classes. I packed the hospital bag with more goodies than anyone could possibly ever need. What I wasn't prepared for was how little I actually knew about my own body and how quickly that truth would hit me after giving birth. I was very fortunate. I delivered a very healthy, beautiful baby boy. And during that process, I suffered a grade 3 vaginal tear. Suddenly, I was terrified. But here is the part that shocked me the most. The silence. My doctor didn't explain how to care for my stitches. She didn't even mention pelvic floor therapy as an option. When I finally asked, her response was simply, "You could look into it if you want to." I went home scared, quietly wondering if the pain and disconnection were just my new normal. I know now that I wasn't alone and that so many women leave the hospital with absolutely no roadmap. That is why today we're breaking the silence and handing you the map I and so many others wish we had postpartum. In this episode, you'll learn what is the pelvic floor and how to identify pelvic floor dysfunction. We'll dig into the symptoms we've been taught to ignore, from heaviness to urgency. The ACL analogy that will completely change how you view your recovery timeline and why the 6-week clearance is often a lie for many women. And lastly, how to vet your provider. We'll give you the specific questions to ask to ensure you're getting quality, trauma-informed care and not another 15-minute checkup. Rooted Exchange turns honest stories into practical tools so you feel less alone and know what to do next. I'm joined by Dr. Jessica Hund, a pelvic floor physical therapist and founder of the Floor PDX. She is the person who helped me reconnect to my body when I thought I was broken. And if you've ever felt tired in a way that rest doesn't fix, or if you're navigating a body that feels different than the one you remember, this conversation is for you. Let's get into it. Welcome, Jess.
Thank you.
I want to start out by talking about how pelvic floor feels so new to us as a concept. Mm-hmm. Even though it's been a part of our bodies and our anatomies, the progression of this type of healthcare is relatively new, growing over the past few years. But really would like to hear from you. Why do you think that this conversation, while growing, still feels taboo or even underground to some regard?
I feel like there's so many layers to that. As a whole, I feel that women haven't been okay with speaking about that area of their body for such a long period of time. I mean, if we even think about our moms, they probably don't want to talk about that region generally, because it has been so taboo and we don't really talk about it. And research as a whole, if we look at the whole medical community, hasn't really been placed into women's healthcare studies. I mean, just recently they determined that or found that all of our hormonal health studies have been done on mice that don't have menstrual cycles. So we're starting at that point. So I'm really hoping that research is slowly changing, but I feel like we as individuals who have vulvas are finally starting to talk about what is occurring to our bodies and normalizing it, because even though it's common, it doesn't have to be the norm.
Yeah. We'll talk a lot about what happens physically, but I am also curious if you have a position around how women feel emotionally disconnected, maybe because of that generational learned aspect of it. Certainly more and more women, millennial and younger, are starting to identify more with it, but that sense of disconnection from that part of our body.
I think that also has such a multifaceted answer to it that I don't think we necessarily all know yet. But I mean, if you have, in our clinic, we hold a lot of space for trauma-informed care because the body keeps score. And oftentimes your pelvic floor or perineal area is where you feel the tension and pain of a lot of things that may have happened to you in life, not even accounting for whether or not you've had sexual trauma. And if you have any sort of sexual trauma in your past, or you came from a purity mindset and that was your upbringing and this is not the place that you talked about. And if you did anything else, that was shame that was associated with it. So anything that happened was shameful in that area. So we don't talk about it. We hold everything everything tight and in, not to mention the diet culture we grew up in where everything is sucked in and tight. And if you're sucking in constantly and you're wearing tight, tight, tight pants, all that pressure is coming down into your perineal area, your pelvic floor area, which is not beneficial for people who have prolapse, who have pelvic floor tension. That's going to do this in response to our presentation. I also feel like we weren't educated in like, eat enough fiber, have enough quality foods. We were just eating like think thin bars, like go lean crunch, like lean, thin, tiny, take up less space. But like no one's pooping with that in their body. So we're also not having great gut motility. That's going to also add to a pelvic floor that's like this the whole time.
Right. It's such an interesting aspect you brought up, even the clothes we wear and how that impacts our pelvic floor. We don't know, a lot of us don't know a lot about how that impact happens. But also then the shame we feel when we start having symptoms that come as part of that. As I think about, my journey and becoming a mom, when I gave birth to my son, I felt like I had done something wrong. Yeah. And maybe there was things I've done over time to not support my pelvic floor. But I also felt that deep feeling of shame and not knowing what to do about it because I was now in a position where I was having a lot of symptoms that I didn't feel previously. Yeah. So how common is that feeling when women and patients come to you that, even with a lack of education, that there's still a lot of, well, I should have known better as part of that?
I think we're trying to advocate for prenatal care like crazy for patients. If you're pregnant, you can come to pelvic floor PT beforehand to talk about what it's going to be like afterward, what it could be like, to give you tools and understand that having a baby is, you can have a birth plan, but that's a really loosely held idea because birth never goes the way that you want it to go necessarily. And then also having a solid framework for postpartum of I have met my mental health therapist and I have their number and I know that we vibe together really well. Should I need to call upon them for help? Or this is what it might feel like postpartum, but don't worry. There's so much more time for healing afterward. And this is what we want you to do from an activity level standpoint. So don't feel shame if you're not jumping back to what you want to previously be because your pelvic floor muscles stretch 3.8 times their resting length to get baby's head out. And people who have C-sections, your pelvic floor still carried a baby for 40 weeks. I don't care if that's 9 months, it's 10 months.
Yeah.
40 divided by 4 is 10.
If you're 2 weeks late, it's more.
It's more than that. And most people are 2 weeks late. Yeah. Because, due dates are made up. But yeah, I think a lot of people, you don't know what to expect if you've never done it before. If you think about anything else, I haven't done an Ironman. If I did an Ironman and I was toast afterward, I would probably have more grace for myself than childbirth, but it's one and the same.
Right. Yeah, and you touched on something really important. Growing up as a child, I remember there being like Lamaze classes. And to your point, there's nothing that can really prepare you for actual experience of birth. But there are things that we can do to educate women about our bodies, how they function, and how to prepare for the moment, the experience. And I don't think that our healthcare system gives enough space and time to actually do that. I went in feeling very blind about what was going to happen. And I feel like I had a lot of support. I had a doula who provided me a lot of education. And I still was like, what's going to happen when we get there? Yeah. The work that you are advocating for in this industry is much needed to help women feel more supported. But I want to back up a little bit. Your work is it's an intimate space. It's part of healthcare and making sure we advocate for women. You don't just treat muscles, you treat people. But I'm curious, how did you find your way to pelvic floor therapy?
I never wanted to do it because at the time I thought pelvic floor therapy was just Kegels, just pelvic contraction. Then I thought if I have to go to school for 7 years and 8 years, however long it was, and I literally just have to sit and be like, okay, squeeze set 10 times. Now going to lunge and squeeze 10 times. I will lose my ever loving mind. Nothing sounds more boring to me. So I didn't want to do pelvic rehab. At the time, that was our lecture in school was 3 hours of that. And I thought that enough was that's all I needed, period. So I went the ortho route and I fell in love with length tension relationships and loading parameters and looking at the whole body system and tolerating whatever you're asking it to do. And then I had my baby and I had no preparation for it. I was a person who was like, the more information I know, the more anxious I'll be. I don't want to know, which is funny because now I feel like I have an appreciation for my patients who come in like that, who are like, I have so much more anxiety if you tell me stuff. So tell me the minimum I need to know, but provide me with the resources so that I feel like I could be held through the process. And that can be very different than the person who's like, no, give me all the podcasts I can listen to, which I am now that person. But I mean, knowledge is power, and you just have to view it as such. But I mean, it can be scary. It can be scary if you're like, wow, I didn't know all of that. I will say 50% of our patients, depending on the time of the year, have never had babies and have pelvic floor involvement. And I think that that's a common misconception, and more shame is associated with it of, I didn't do the thing that warrants me to be able to say that this is why I have pelvic floor involvement. But there's so many other reasons you can have pelvic floor involvement. But for me, I had a baby. She tore her way into the world, which I didn't even know was a thing before I had her. And then afterward, I was like, wow, I don't even know what to do from here. I was told I didn't need pelvic floor therapy. I could if I wanted it. Which I was like, well, fine, I'm a PT. I'll figure it out myself. So 9 months went by and I was still leaking with running and had such pain with sex, which also brings shame because you're like, I want this relationship, even though your partner's not giving you shame. Like, you want to return to that. And if your body's not doing the thing it did before, how do you get it to do the thing it did before that you want to do, but it's painful, which brings shame. So I went to a pelvic floor PT. Took forever to find one. And she told me, this was during COVID time, that my liver was the primary reason for my pelvic floor problems and that I'd had too much to drink, which I had not. And she could feel it, which you can't. And I thought, wow, if this is the level of care we're providing for pelvic rehab, I am doing a disservice to the people I know and love if I can't learn more about this and teach them about it. So then I dove into the pelvic floor PT world to primarily and selfishly fix myself. But what I found in the process was we have so much stuff that's coming out from Australia and around the world where people are doing pelvic rehab completely differently than I thought. And because I had a knowledge of how muscles worked intimately, I was like, there's 3 layers of 3 muscles. They work the same. It's all about load, tension, and capacity. And arguably they're cooler because there's 3 canals that go through. And then you're playing with pressure management and landing systems. And because I actually have a psychology minor, which is funny now that I look back on everything, I love that side of things. Like, I can meet you in a space where you feel the most vulnerable, perhaps. And then I also feel like we have an army of people that we've created who we hold hands with when we realize how do I phrase this? I'm a huge advocate for knowing what your scope of practice is and being really damn good in that scope of practice. And then knowing when you hand it off to someone else who's really good at their scope of practice. So I'm not a mental health therapist. Right. Yes, I know how to do trauma-informed care, but I have an army of people who I trust to co-treat, and collaboration is massive for me to be able to walk with you to where you want to go as a patient. Even just talking about how women's healthcare, going to those appointments, let alone getting treatment for this, is not looked upon with what those women may have experienced in their life, and the challenge, A, showing up, B, being physically and intimately touched in a place that may be painful, brings a lot of baggage with it inherently in its nature of a practice. So I think it's really important and amazing that you guys continue to look through it through that lens for the safety and well-being to encourage women to get help and feel safe in a healthcare space. I never want our patients to feel that physical therapy is being done to them. I want it to be we're doing this together. I'm providing the tools for you to be able to come alongside with. So most of the time, every time in our evaluations, we tell our patients, this is your body, remind you. You're the one dictating if this feels safe to you at any point in time. I mean, an intravaginal assessment, that's a pretty vulnerable assessment. And though vulvas and vaginas now feel like elbows to me, it does not to everyone else. Right. So understanding that, first of all, welcome to our space. This is what it looks like. Hi, this is who I am. Let's talk about your history together. We don't have to do an intravaginal assessment. Right. You can decide next time if that's something you want to do or if you ever want to do it. But don't feel like that's the big elephant in the room that we're going to get to because we have to do it on your first appointment, because we don't. No matter what, this is you dictating how we're going through care. And I don't know your whole history. I don't know if you were abused when you were a kiddo. And that will massively dictate if you feel safe in this environment for that progressive care. How did your definition of healing
change over time since it's something that you necessarily didn't think you were going to get into. I want to call out that just like any other PT, if I tear my calf, I get treatment, we go through a protocol. I think a lot of women don't think about this kind of care the same way as we do any other muscle. So how can we think about this care in alignment with our whole body?
Yeah. I think that goes back to people thinking that when they have to get to that 6-week mark and they're cleared for activity and exercise and they're fine to return to everything. That's just a arbitrary number that people are given as like clearance. 6 weeks is arguably the soonest time you're going to see, like, if you had a scar from tearing, heal. Yeah. That does not mean that your muscles are 100% back to what they were doing before. We had a patient the other day who was cleared virtually at 3 weeks by their doctor to determine when she felt ready to go back, but her mental health wasn't doing great, which he didn't know because he didn't have enough time to check that with her. Yeah. I don't think. So she went back to Orange Theory at 4 or 5 weeks and just tried to do lunges and things felt like they were ripping. And she was like, but I'm back to, like, I'm good to go back. Yeah. So from like a tissue healing perspective, we advocate and educate our patients all the time that those muscles were stretched to such a degree that if you look at close, like a sarcomere of a muscle, you've got actin and myosin that overlay on each other to produce force. It's grabbed on and pulled to create force. But that means that the muscle relationship has to be correct. So like you can produce more force if you're in the middle of a bicep curl versus if you're at the very end and you're trying to lift it up. Yeah. That's because you were here and you're trying to get force, but they're barely overlapping. Right. So as these pelvic floor muscles, aside from the fact that they could have like true injury to them, there could be avulsion off of the front of the pubic bone, which happens in 40% of people. Mm-hmm. Besides that, these muscles are slowly returning to their length tension relationship. So they can't produce the force they're expected to, never mind the fact that they probably had some time off. Yeah. Minus the trauma. Sure. And then you look at the whole body physiologically. If you hemorrhaged at all, if we're looking at you as an athlete, you're on the lowest quantity of sleep you've ever had, doing a task that's probably leading to have a high quantity of anxiety. You're also, if you choose to breastfeed, that's a huge energy consumption thing. Even if you don't choose to breastfeed or if your body's incapable of breastfeeding for a variety of reasons, mental health wise, physically, mastitis, there's so many reasons, your body's still stopping the breastfeeding process, which is a huge physiological demand. Right. So the demands placed on your body in that period of time are massive. And yet we expect it to, come on, let's go. Yeah. So it's like looking at someone who's just had an ACL surgery and being like, let's go run, which you would never do. Yeah. 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 I don't want to demonize the healthcare system, but I do want to share, I had a vaginal tear with giving birth to my son and was really surprised to find out I had week after week of appointments from my OBGYN. And the day that my son was born was really the last day that I got care. And having stitches, having symptoms, I didn't even get an internal exam to check on the stitches and how it was healing post giving birth. And I think that is an experience that a lot of women also experience, and feeling the unknown of, well, am I supposed to do something? How am I supposed to care for this? And I felt prepared to ask those questions, which I didn't really get answers to, but there's a lot of women who also don't. So I know that healthcare is busy. There's a lot of reasons around insurance and things that propel that, but why are we seeing this gap if it's such an important part of repairing? We do it for every other part of our body, but we're just like, all right, women, you got this. Get back out there. I know a lot of incredible OB-GYN physicians who feel so frustrated because they feel handcuffed in their ability to provide care in an insurance model that only reimburses for X amount of postpartum appointments. And I know OB-GYNs who sit in the office and talk well past the 15-minute mark or 8-minute mark because they have a huge quantity of patients for a period of time. I think having someone, and this is why we also advocate for coming into physical therapy postpartum so soon. We have you come in at 3 to 4 weeks postpartum, not because we want to do internal exam, not because we want to get you into the gym doing anything, but because we want to check on you, check on your blood pressure, check on your mental health, and have another point where mama's taking care of.
Yeah.
But then also we sometimes help with curating a list of these are the high points I want you to hit in the first couple minutes of your appointment with your healthcare provider so that they know, because it's hard when you come in for your first appointment, especially if you're bringing baby in and you're like, I don't, it's my first time out of the house. Hi. And then the appointment ends. And you're like, I didn't even mention what I needed you to look at. So I think that there needs to be a big change in the healthcare system. I don't know how long it's going to be or if it'll ever happen.
Yeah.
But I think there are definitely ways that you can play the game more advantageously if you know how to play the game. But that's the key.
Right. And we'll talk about it. I want to talk a little bit later about advocating for those conversations in the moment. But before we do, I do want to dig into what is pelvic floor. So for folks listening and who maybe didn't get education or learning more about this, what actually is pelvic floor therapy? What does it consist of, entail, and support for women?
Yeah. So the pelvic floor as a whole are 3 muscles. This is just showing the deepest muscle. But group of muscles. The pelvic floor is 3 layers of 3 muscles per layer that essentially attach like a trampoline anteriorly to all the way back. And they have different roles within the body, whether or not they're helping to stop the flow of urine as a urethral sphincter, whether the help just provide support. They're important for sexual health, stability, orgasms, getting out the way for you to poop, but also stopping you from when you don't want to poop in public. Same thing with stopping you from peeing when you shouldn't pee, getting out the way when you need to be. They're key muscles in pelvic floor therapy. We look at the whole body and system's capacity to do things. And for some reason, like you mentioned with if you're going in for a calf strain, they watch you do the thing you can't do in PT. Whereas for some reason in women's health, we've stepped away from, or we historically had stepped away from not watching people do the thing they couldn't do. So like if someone said, I leak or I feel heaviness when I'm lifting my kid over my head, or if I'm lifting bags into the back of a car, we never had them do the task and then watch what happened. But we do, so we do vaginal assessments. So we're looking at the tissues of the vulva. How do they look? Do they look like they're low on estrogen? And when you look low on that estrogen, that can influence a lot of things. And we advocate for you getting topical estrogen cream, which you can get pretty readily from providers who are on board, to make sure that these tissues are happy and they're not choosing, it's not that they choose to, but tearing. And then we do intravaginal assessment, and we are gloved up. You're lying on a Chuck's pad with a sheet over you, and we're walking you through feeling all of the muscles I just talked about. And we see, can you contract them? Can you lengthen them? And lying down. But then we get you into standing, doing the task you couldn't have done. So if it's my kid over my head, well, how heavy is your kid? 30 pounds. Great. Let's bring in a 30-pound weight. We're going to have you draped like your Grecian goddess with the sheet tied on your side, and we'll be kneeling, moving with you, seeing, okay, how's your pelvic floor coming to the party when you're doing that task? Or when you stand up, is she suddenly not wanting to come to the party? We treat very much with a dynamic systems theory. And the idea of that is we set up the environment to elicit the task we want you to do. Because in the motor control world, if we over cue you, we won't get what we need out of your body to perform. So much of what the pelvic floor does, you don't need to think about. She just needs to come to the party. And that means that we need to set up the environment so that she needs to come to the party to be able to do the task. So there's different ways that we can do that. But as a whole encompassing view, pelvic floor therapy, we look at how your pelvic floor is moving, where she is resting in your body, if she's really overactive and tense, or if she's able to move with you, if she's painful when we touch it. We teach you how to lengthen your pelvic floor, and then we get you doing tasks with an incorporation of pressure management, load absorption, and hip to pelvic floor relationship, because there's a huge relationship there.
Yeah.
Yeah.
You know, you just were touching on a handful of things, urgency around pooping and pain. There's a lot of symptoms that can come with becoming a mother, or even pre-having a baby, around pelvic floor dysfunction. What are some of the most common symptoms that women face that would be indicators that maybe there is some dysfunction there?
Yeah. The most common we would say is any pain with perineal pain, and perineum is like what would touch a bike seat underneath your undies. Perineal pain, and that can be vulvar pain, so the outside vestibular pain. entrance or entry into vaginal canal pain, so pain with sex or intercourse. Sometimes people who can't have an arousal have pelvic floor involvement, but they don't know it. Having prolapse, having constipation, if you've hit all the other low-hanging fruit. Urinary leakage, so stress incontinence. If I'm coughing, jumping, sneezing, and I'm leaking, that's probably a pelvic floor problem. If I have urinary urgency, so when I get home and I put the keys down, I have to run to the bathroom immediately or I'm peeing. Sometimes you can be ruled negative for UTIs, and they've done all the swabs of all the appropriate areas, which oftentimes the areas they're swabbing are not the right areas. So check for that.
Good question to ask.
But sometimes it can be that the pelvic floor muscles in the second layer are so overactive, it's causing the same urgency and irritation, but they just need to learn to return to their resting position. So
Sure.
C-section sensitivity. Sometimes people want to dissociate from their C-section scar because that was not the plan, or it was an emergency C-section and there's a lot of trauma there. And this can get so tight that you end up here and you can't get extension and you can't get a full deep breath in.
Yeah.
But yeah, I would say urge incontinence, stress incontinence, mixed incontinence, the combination of two. They're trying to make a subcategory of athletic incontinence. So if you're doing, which I feel like life is athletic incontinence, but it's fine, but like barbell tasks, dumbbell tasks, kettlebell, and that's causing leakage. Pain with intercourse or intimacy, difficulty pooping fully, inability to fully empty your bladder, heightened quantity of times you have to pee per day. All that's pelvic floor.
Thinking about this from some of the shame that we talked about, and also this just being an intimate healthcare setting, I think I was a little bit skeptical or hesitant about what it would entail. But knowing that I fell into some of those symptoms and I didn't want to struggle with that, felt that it was worth it. But do you have any thoughts or insights for women who might be still hesitant while struggling with those symptoms about how they can get started or what it means for them long term if we don't treat these muscles?
Some of the urinary stuff is controlled by the brain significantly. And so a lot of habits are pretty easy to change if you know how to do it. We talk about addressing low-hanging fruit because there's so much stuff that you can start that has a huge change in the end. It's not going to naturally get better by itself if you've had it for a while. Yes, pelvic heaviness directly after birth should get better. But if you've had something going on for a long time, or you know that your mom suffers with it and it's genetic, then you most likely should get a look at it. But I think, and maybe this is just because I'm in the world, but so many of our patients say, it took me a year to come in and I was so nervous to do it. And this is so different than what I thought it would be.
Yeah.
So I would say just try, be brave and try. And we don't have to do anything. We can just talk about your history if you're comfortable doing that.
For the women out there who are seeking care and trying to advocate for themselves in this space, I think there are a lot of providers who don't provide the level of care that you look at. Are there a specific question or two that can help you understand if that's the right provider for you and can help you address those things while also feeling safe?
I would ask if they're a trauma-informed provider, 1. 2, I would ask them how they assess your strength of your pelvic floor. And if they don't do a standing internal assessment, then I would highly question going to them because that's important. If you have symptoms in standing, you're not lying down. 3, I would ask them how they do strength measurements around the pelvic floor. If they're just saying that they're doing manual muscle testing or pushing to my hand a certain period of time, that's not the gold standard of strength testing. We have an inline dynamometer where we can actually see percentage difference from side to side and actually track what kind of change you're making over time. I also, and maybe I'm biased, but I would ask whether or not they have aides or assistants in their practice because I don't feel like you can provide quality care for something that's so intimate if you have a revolving door of new clinicians that are coming in over and over again. You see your provider for 2 minutes and then it's an assistant or a different aide or a different assistant than what you're used to. It's one thing if you see the consistent person each time, but most of the time those clinics that have aides or assistants or PTs are high volume clinics and there's a lot of different faces that are coming through and you're not going to get progression, 1, because they don't know your story.
Yeah.
Because they haven't worked with you the whole time. And 2, you might not feel safe enough to tell them what you're feeling. I would also check if the rooms are truly private or if they're just curtained off, because some places have only curtains that are separating you from people and there's nowhere you're going to relax in that kind of environment.
As we think about this in a PT environment, I think we see a lot of blanket statements happening around with other parts of your body. So you have a knee, it's going to take you X amount of weeks to recover. Some women may take 3 months, 6 months. There's a lot of range in that. How do you speak to that part of it in encouraging that if you have the right provider that is supportive?
Yeah. I think it just needs to be individualized. It needs to not be a 2 to 3 times per week for 6 weeks. We rarely see people 2 times a week because you've got us for 60 minutes. We give you the homework to do. You work on it, and then we recap together. And then we give you, as we progressively are seeing change and your body's making leaps, then we give bigger gaps between the different appointments that we have so that we have time to see, okay, over that period of time, how are we doing? It's individualized care, which is what physical therapy should be.
Yeah.
Yeah.
For someone who is pregnant or newly postpartum, you talked about how quickly you like to advocate for them coming in to see you. How should women think about building that into their process just the way they do with baby, right? We do their 1 month, 2 month, 3 month checkups just to even just make sure that everything looks good and is functioning the way it should, or what needs to happen next.
I think that's why doing prenatal care is so important, because we get a baseline for what your pelvic floor looked like before you had baby. So we have patients who have uncomplicated pregnancies who don't have pubic symphysis pain or low back pain or diastasis recti that's bothering them or something like that. And we have them come in without other things going on 2 to 3 times before they go into labor, because we want to talk about birth prep. We want to set you up and schedule your 4-week postpartum appointment, because if that doesn't happen before you have baby, it's not going to happen.
Yeah.
And set up a game plan for understanding what it's going to look like afterwards.
What about mamas who are 10 years down the line?
You're still postpartum,
and still
not a baby.
Well, and still fighting some of those symptoms, but living with it as normalcy.
Yeah.
Is that something that can be addressed that far down the road? How can mamas who maybe didn't get the care first time around start thinking about what support might look for them now?
Yeah. They're muscles. So they're going to learn the thing that you give them to do. You provide stimulus and that change will happen. And again, there's so much low-hanging fruit from a behavioral perspective that you can readily change that you might not realize you're doing until you have an outside perspective looking in. And I feel like that happens pretty regularly, that people don't recognize that the moment I get home, I run up the stairs to pee. But can you not do that? I don't think I can't not do that, but I haven't thought about not doing that, because I always do that.
Right.
But we don't want your bladder or your body to dictate how you experience your life. So there's so much change that can happen years after you've had your baby. So to think that you have lost your window of opportunity is not true.
I want to close out and just kind of ask about how can we better normalize these conversations? I think it starts with ourselves as individuals and just acknowledging this part of our body that serves a great purpose as women. Men have pelvic floors as well, but especially for women. And then also normalize the conversations to have these discussions with our partners, have them with our friends, and then also make sure that we're having them with our providers.
I think if you start small, it's less overwhelming. So being comfortable with speaking to your partner about what's going on. Step 1, if you feel like your partner is a safe person to talk to, and then speaking to your immediate community, your friend group, because I think you'll hear a lot of me as well. And that makes you feel so much less isolated. And if there's anything that I've learned in the postpartum phase, isolation is one of the biggest feelings it can feel real quick when your world is on a 3-hour cycle that just repeats over and over again.
If you could whisper one thing, one piece of advice, one truth to women listening about body, about her pelvic floor, what would it be?
That she's worthy, period. And that she's worthy of investing time into herself. Because I think that there's so many people that don't think that they need the time or that they're worthwhile in giving the time to. And in a phase and stage of life where phones are up all the time and computers are up all the time, and we've lost the human connection of touch and I see you, to hear someone say, you are worthy and loved, period, and let's get you better is so important. So the baseline, I think that if I could whisper into anyone's ear, is you're worthy. Yes, of course.
Thank you so much for joining us today. I really appreciate your time and just really digging into this topic.
Thank you for having me.
Before we close, I just want to pause here for a moment because what Jessica shared at the end feels really important to sit with. You are worthy, not after you heal, not after you stop leaking, not after your body goes back to what it was before. You are worthy now, worthy of asking questions, worthy of care that feels safe and respectful, worthy of taking up space in your own body again. If this conversation sparked questions for you, maybe it was recognition, maybe discomfort, maybe it was relief, know that you're not late to this. There isn't a window you missed. Healing doesn't expire 6 weeks, 6 months, or even 6 years postpartum. And if you're someone who's been quietly living with symptoms like leaking or pain or heaviness, or even just a sense of disconnection, please hear this. Common does not mean normal, and you don't have to carry it alone. A few gentle reminders as you step away from this episode. You deserve a provider who is caring and trauma-informed. You deserve care that is done with you, not to you. And you deserve answers that don't end with, "This is just part of being a woman." If you'd like to learn more about Dr. Jessica Hund and her work at the Floor PDX, you'll find links and resources in the show notes. And if this episode made you feel seen, I invite you to share it with a friend, a partner, a sister, or a fellow mom, because these are the connections that pull us out of isolation and back into connection. Thank you for being here with me and for listening with such openness. Take what you need, leave what you can, stay rooted.